So our routine is to do both a transthoracic and transesophageal study before people have general anaesthetic, so that you get stable haemodynamic conditions. It's useful because there's usually a delay between the pre-implantation TOE and the day of implantation, and sometimes our operators are different. So the person who's monitoring the procedure on TOE, it's really important that they get an idea in their own minds of what the left ventricle looks like, whether there is a pericardial effusion, the size of the aortic root and the appearance of the aortic root, the degree of mitral regurgitation, and the calcification and arrangement of the aortic valve, so that if there are complications during the procedure, you immediately know whether there's a change before in your own mind. And a point to bring out really in discussion with your interventionist is that the left ventricular cavity is hypertrophied and relatively small. There is some caudal calcification in the long axis view, and there are normal occluders moving. Going into a long axis to assess left ventricular outflow tract velocity time integral. There is also some aortic regurgitation, which is useful to know about, because our suspicion is that those people who have pre-intervention aortic regurgitation probably have greater resistance to post-operative residual mild paravalvular aortic regurgitation. Forward flow velocities across this valve are 4 meters per second with a mean grade of about 37. Aortic valve area, I think, has come out before as about 0.5 centimeters squared. Forward flow through the mitral valve we know is normal, but we'll need to just double check that because there may be wires passing and interfering with the mitral valve apparatus. Normal closing volumes, normal leaflet, normal occluder motion, no attached masses or vegetations, and back onto the most important part of the study, trying to assess the aortic valve. In this case, we're troubled by the presence of the mechanical valve because you can see that there is a great deal of reverberation artifact. There is a problem here because our pre-test assessment has suggested a valve annulus of 23, and actually on this I think that these are probably underestimated, partly because of the reverberation artifact. I've done a lot of measurements, and I think that probably the most reliable, at least this is a symmetrical annulus measuring at 2.5 centimetres, which is really at the upper limit of the comfort zone for a 26mm valve, and I think under normal circumstances we would probably in this patient upgrade to a 29mm. So we have a discussion about whether to use extra balloon dilatation in 26 or undersize the 29mm valve. There is also the issue that with the implantation of a larger valve, there is the possibility of compromise of one of the occluders from the mitral valve. I've done a 3D showing the occluders of the mitral valve to be working well. The mitral valve is interestingly slightly displaced within the dilated left atrium over towards the aortic root in this patient, which is further going to raise some issues during implantation.